Okay, so let's start with the next topic of the course. Can you see it now?
Yes.
So this is very complicated pathologies. These ones are very complicated pathologies. I don't know, but they are just giving 1 hour for this. Okay, 1 hour for this pathophysiology of the demyelinating diseases. So we're gonna see it actually quite fast, and I'm gonna give it the key uh, the key parts of the diseases or the pathophysiology of them. But what we need to understand is the core physiology terms that we need to check. So if by the title pathophysiology of the demyelinating diseases, what do you understand?
Like for example, the neurodegenerative diseases that have to do with, well, that basically, I don't remember their name, but there's like two main ones. They basically generate like trouble with people being unable to move or having issues to move like their limbs, and that starts to progress and generates like sometimes some kinds of paralysis, I think.
Okay, yeah, but why? I mean, it's
Because
super good.
they,
It's super good, but why?
can I say it in Spanish?
Yes, of course.
O sea, porque las zonas mielinizadas de la neurona básicamente sirven como conductores de electricidad, y la electricidad va saltando de entre esas zonas para como tener una conducción más rápida. Pero pues cuando esas zonas se van desmielinizando, básicamente genera como que pues haya problemas en la comunicación neuronal y pues no estén llegando las señales de manera adecuada, y aparte se deterioran más las neuronas con, o sea, con esa energía como que no se está realmente como expandiendo.
Okay, yeah, perfect. I mean, this is a overview of exactly what's happening, and if you remember what we saw late at the beginning when we were talking about the headaches, that we have different fibers, right? We have different nerves that communicate from different parts of the body to the brain, and depending of the speed of this communication, I mean, we need different speeds, and that actually depends on how big the nerve is, but also how is the myelin in this. So the first question that I have is, what is myelin then? What do you know that is myelin?
It's a substance that has lipids and proteins and like, well, that's mainly it, and it is like it forms a kind of like barrier for protection in the axons, in the neurons. I think that's generally it.
Yeah, it's in the axons, as you were saying. Yeah, basically, it's this, right? So this is what we have. We have a neuron that is. If we talk in the central nervous system, we have here the oligodendrocytes, right? This is part of glia, as we were talking yesterday. Remember, we have different subtypes of glia. We have astrocytes, microglia, oligodendrocytes, and then they have different functions. In this case, oligodendrocytes in the central nervous system, what they do is they produce these lipids that they go around of the axon of the neurons and then generate this isolating part, right? So here, for example, we have the node of Rambier. What is happening here? You were telling me. What happens in these nodes of Rambier?
That's where the energy jumps from one node to another with the help of the myelin.
Yeah, I mean, yes, kind of. So just to be very, can you see the whiteboard?
Yes.
Yeah.
Perfect. So basically, what we have here is this is the axon, right? This is the axon, and then here we have like this is myelin that comes from these oligodendrocytes. And then we have another one. And then we have... So and these are the Rambier nodes, or nodes of Rambier. What is happening here? So this is in the membranes here. In the membranes here, we have that the action potential is renovating all the time, right? Here we have sodium and potassium. Remember that is very important. So we have sodium, and then we have potassium, and then we have here our action potential, right? Are we having action potential here inside? What we know is that we have this saltatory action potential, right? That's why we have these nodes of Rambier. Because actually what is happening is that the electricity, so here in all of these parts of the membrane of the axon, here we don't have sodium and potassium channels. So that here we don't have action potential. But the positive charge of the action potential is traveling around here, right? And then the problem is that if one of the things is why we don't have the whole action potential with these nodes without these nodes. Why we need to have this node? Why we just not close it everything and we continue? Why do you think that is happening? Someone. I mean, I want you to use your imagination. Tell me why do you think that's happening? I saw the cursor of Paula. What do you think?
Well, maybe the myelin doesn't let it pass, but I don't know why. Maybe because it has positive charges. I don't know.
I mean that could be something. I mean, what happens is that the charge can start becoming weak and diffuse. So then the positive charge start going to other parts that they shouldn't be. So this is a oversimplified part, right? So the charge start to going not as positive as or the membrane is not that positive anymore because the positive charge that enter here is start getting diffused in all the organelles inside of the axon. Remember that we need to reach minus 40 to have an action potential. So that's why we have these nodes of Rambier. Here we refresh the action potential. So what is happening here is that the electrical conduction is happening, and then here we have again channels, and these channels they are voltage sensor channels, and then they reach -40, and then they have the action potential again, and then it happens again. Okay, that's the basic part of why we have myelin there that is helping us. Questions here?
No.
Understood? Yes? Okay, perfect. Question here. Now, what is the, so this is, for example, for these are oligodendrocytes. These oligodendrocytes are for the central nervous system, but the peripheral nervous system, how are these cells that they are actually making the myelin called? Do you know? Do you have any idea?
There they are, the oligodendrocytes.
The oligodendrocytes are in the central nervous system, but in the periphery.
The Schwann cells.
Schwann cells.
Schwann cells, yes, perfect. So they do the same, right? And then basically this is myelin, a fatty protein that grabs around the 5 nerves and increases the speed of electrical signal transmission. So under the electron microscope, they look super nice, right? It's just like you have a rubber band around the axon. It's super cool. This is what I told you. 1 millimeter segment of the axon. And for example, an oligodendrocyte can actually cover 60 axon segments, which is crazy. And after birth, we continue remyelinating the cells. So this is, for example, how it works. We just explained it, right? The problem is the demyelination. If you kill any of these cells, then you cannot synthesize the myelin. If the myelin cannot be synthesized, then this is gonna disintegrate. And if this disintegrates, it's actually not protecting the axon, and then you have disruption of the action, because the action actually cannot. Like this also has to be with the size of the axon, and they cannot actually produce as much as a protein as they need to actually have all the membrane with the with the channels and with the receptors, etc. So then we have this disruption of action. The disruption of the axons. And how this happens and is mainly because of autoimmune disease. What are the systemic autoimmune diseases? What do you understand by autoimmune disease?
It's like disease where the body is somehow triggered by itself and starts attacking tissue of the like inside the body, which starts generating many problems because it does not happen in like inside.
Exactly. So
Like there's not an external attack.
Basically, it's your system gets totally confused, and then they start attacking your own. Your system start attacking itself, right? the problem is that there is nothing that actually can tell us that there is that happening. And one of the main diseases, then maybe this is the one that Andrea was talking before, it was the multiple sclerosis, right? So, for example, here we have that after a lot of damage in many of the axons, then we start having problems in the brain, the vision, the spinal cord, and the mouth speech. I mean, it basically affects all the neurons that on all the functions of the neurons that we have. Okay, so this is I'm not. I mean, you can read this, and this is the definition of multiple sclerosis. We have some of the epidemiology here that is normally is affecting more women than men. As we talk, it causes the loss of axons and neurons, and if it's not treated on time, then it will generate life-threatening conditions and actually severe disability. Here, the autoimmune process involving autoreactive lymphocytes and major role in pathogenesis. And yeah, I mean, this I just pasted here for you to, like, this is the how it's called, the main takeaway of multiple sclerosis, but we're going to check it one by one. This is something very, very, very confusing about this disease, right? So the epidemiology of these countries, like this is where I'm living actually in Sweden, but you have more cases when you get further away of the equator. Why? Why do you think that this is happening? So you have less cases here, where in the middle of the planet, and then you have more cases on the north or in the south. Why do you think that could happen? Who wants to adventure an idea?
Maybe it could be like something related to genetics, like, or antecesores. I don't know.
Yeah, it could be, but so, like, what do you think is very common on these parts of the world?
Maybe the cold.
The cold, okay, that's one, and the other is the darkness. Okay, in these countries, what we have is that there is very few hours of sun during the winter, a lot of hours during the summer, but we are basically in December, for example, or on the dark months that I think is January. We have actually it's December, that it becomes night at 2:30, for example, where I'm living, 2:30 p.m. And then the sun comes out at 8 in the morning. So we have around 6 hours of sun, and that makes a deficiency of vitamin D. And that's why these countries, they have more incidence of MS in this part. Okay, so there is a lot of hypotheses on the etiology and the pathogenesis of MS. We don't know is become that actually activates our system to recognize the myelin as not ours and attacking it. But they have seen that there is, like, for example, some viruses that actually redistribute or reprogram our defense system that actually generates this uncontrolled immune response. And we have these autoreactive T lymphocytes and monocytes that actually are attacking the Schwann cells. And well, not in MS, we're talking mainly about the oligodendrocytes. It's interesting because these are environmental factors that actually are thought to contribute to the pathogenesis. For example, this is what I was talking about, the low vitamin D and sun exposure, this virus, the Epstein-Barr virus infection, smoking, adolescent obesity, and high salt intake. How these people actually got to know that, it is incidence of how most people have are more susceptible to MS. So in the pathogenesis, the tricky part is to actually understand when or where it's starting. We are talking here about the central nervous system, and this is important because I'm going to make a difference between two diseases. And basically is how the in a focal part, like in a specific part of the brain, they start getting attacked. The myelin is, basically the oligodendrocytes that actually destroy the myelin sheets, and then the axons, and first the axons are degenerated, and then the neurons can also die because of it. The other part is that, and this is what I was talking yesterday about, when you have a problem, a lesion in your brain, then you will have scar tissue, and this scar tissue comes from the astrocytes, right? So we have these glial cells that they're supposed to protect, but then when they accumulate, they become like, instead, imagine you have neurons here, and then that neuron died, or these axons died, then the astrocytes are coming here and covering that part that shouldn't be empty, and then that is what we know as a sclerosis or scars on our brain. So this is for example, a hallmark of the pathologic of MS, that they will have areas of the brain where we can reduce. And I think I have something here. Yeah, for example, who can tell me which one do you think that is the normal brain, the A or B?
B,
B, why?
because it has like the white matter is like more clearly defined, and
Exactly.
there's like not as big of splotches of dark as in the other one.
Yeah, so this could be interpreted perfect. Thank you, Laura. Like this everything, it could be interpreted like a scar tissue, right? I mean, it should look like this, but then in A we have this part. So in the pathogenesis, we can make three big groups. One is the viruses that I was talking before, then a CD4 plus autoimmune process of lymphocytes, and then autoreactive T lymphocytes that they are causing this inflammation and demyelination of the brain. So we have a temporal course of MS we have a relapsing remitating temporal course. We have a secondary progressive, a primary progressive, and progressive relapsing. So this is when actually people get diagnosed, because they have something that happened, that it could be a motor problem, and then they do the clinical evaluation, and then they found out that is problems with the white matter. So basically what we have is like relapsing, remitating. So it's relapsing all the time, getting worse and worse. Then progressive, like it's also relapsing, but then it becomes worse and worse. And it just goes nuts in the primary progressive. And then when it's getting worse, then you have sudden attacks during the progression of the multiple sclerosis. And basically what we have here is that when we are having like this demyelination of the brain, we are having loss of axons, and then the brain volume start to decrease, right? If you are killing the cells, you are going to have less brain volume, and that, of course, it's just, you're just killing your brain faster than it should be. The clinical features are repeated episodes that they again, how do we know what is happening to these patients? For example, it happens more in the motor connections. That is what we can actually check at the beginning, but everything depends in which part of the brain we are finding the demyelination, right? So if we are talking about, again, if we remember what we have seen these days, we were talking about the motor cortex, the visual cortex, the somatosensory cortex, and everything. So that's what's going to happen. If we have diverse sites in the CNS affected, we can have an episode that can be distinct from other ones. And then in the relapsing remittent type, so you will have more cells dying as these events are happening. So something that happens that is the clinical features that we can check is that we have some retrovular neuritis. You can check here how the one part of the one eye is not following as it should be. You have zigzag vision. This is the oculomotor disturbances. Lermit time, that is actually positive neck flexion sides. Sensory disturbances. So basically, what is happening in these patients is that actually they lost totally the reflexes in the body, and urge incontinence, and then when things are getting worse and worse, then they have troubles to even walk. Something that we need to take care when we are having MS is that we need to take care of the inflammation. So when the brain is detecting that our own body is getting like it recognizes as external, then it will launch an inflammatory response, right? So what we need to do is actually limit that inflammatory response, and then that's why we can use, for example, corticosteroids. And actually, it helps, but it takes a lot of time, and this is not gonna change the course of the disease. Then we have to give immune modulating or immunosuppressive treatment. And to prevent that this goes worse and worse, we're going to take this TR, the inhibitors of T and B lymphocytes. But that comes with a price, right? So we need these T and B lymphocytes for something to actually recognize and external factors. So these patients, they have to be very well follow up later on. And this is, for example, what happens with the MS. That patients will start having problems to connect their brain to the where they have to deliver the neurotransmitter. So they start having a loss of the brain tissue, and depending on where this brain tissue is dying, we will have sensory problems, motor problems, reactive problems, and then it can advance as fast as is without treatment, and to actually even have a fatal outcome. So, but what about this is, and that's where I was making a lot of emphasis on the central nervous system. But what if our system, instead of recognizing the oligodendrocyte as external, the myelin, that kind of myelin as external, we are talking about the peripheral nervous system in the same myelin function? Well, that is called the Guillain-Barré syndrome. In this case, we're talking about the peripheral nervous system, and it's this actually the major cause of neuromuscular paralysis in the US. And then we have two subtypes of the Guillain-Barré syndrome. One is called the acute inflammatory demyelinating polyneuropathy. That is actually the most common in the US. And then we have acute motor axonal neuropathy. That is supposed to be more common in South America and in Asia. So this is bilateral peripheral facial nerve palsy in this Guillain-Barré syndrome. And the clinical features here is flaccid weakness in the muscles. Leg weakness is actually often the early sign, but it can go to other extremities. They also lost the reflexes. This is areflexics. It means loss of the reflex. The weakness progresses over 1 to 3 weeks. It's like first goes very high and then it keeps going. That's what the plateau means. Yeah, I mean, it's also life-threatening. Like the outcome, it's not very good. Yeah, so we have the pathophysiology of the AIDP, and then we have also the pathophysiology of AMBA. I don't know if we continue next. Oh, sorry, let's see. Okay, I think we are going to stop here. But before I go into more detail in this two Guillain-Barré syndrome, I want to ask if you have any question.
No.
No, thank you.
So then tell me what do you think about MS? What is something that you you find more interesting about the MS. On Thursday, I'm gonna ask you what do you remember about this and how actually it's happening. So you can take advantage now and ask me about this.
Well,
What? Yeah, Laura.
what I find like the most interesting is the cycles that it works on. Like it starts with one episode and then it stops and then it starts to generate other episodes with more and more gravity. I think that's like a very
Yeah,
interesting way for a disease to work. Yeah.
Yeah, that's so these are basically what it happens to the patients is that they actually like they get a big wave of response of the autoimmune response all of the sudden, and then it comes back and then it continues. Actually, I recently saw a movie about this. I don't remember the movie. I would try to find out that it was a nice movie about what happens to the patients when they have these attacks or relapsing attacks. Is not nice, of course. Okay. Any other question? No? Okay. If there is not any other question, then I will stop for today, and then I will put the two presentations. I will upload them in Canvas, and then did you receive now? It's in your dashboard that you have to deliver something for next Friday. The activity too.
No, in the dashboard, no.
But I actually assigned them to all of you, one by one actually, because it was not.
No, it doesn't appear on the calendar, but it does say
Yes.
the date on the homework. I don't know why that would.
The assignments.
Yeah, if you enter the assignment, you can see like the
Okay.
date assigned, but it's not like appearing on.
Okay, well, then I am telling you now, it's on Friday, like the assignment for the week 2, and I now will try to do a couple of quizzes for these topics. Okay. Questions? All good? Okay, then see you on Thursday. And the one that I didn't put the assistants can tell me, and then we can fix it. Have a nice day and see you on Thursday.
Thank you, doctor.
Thank you, doctor. Have a great day.
You too. Bye.
I wasn't when the assistant was taking.
Me either.
Yeah, me either.
Bye. What's the full name, Vale?
Valeria García Ovalle.
Well,
Me, Laura Carrera Castillo.
okay. ¿No? Ah, qué bueno. Estrella.
Yes.
Okay, perfect. Thank you. See you on
you.
Thursday.
Thank you, doctor.
Bye.
Bye.